Okay, so one of the issues that we get asked a lot is about helping to start insulin, and I just want to review a few of the basics today. We all know that blood glucose levels are the lowest prior to meals, and then once we eat, we have a spike in our blood sugar. Then it overshoots a little bit and comes back down to baseline. Our plasma insulin basically follows the plasma glucose. And when we're giving insulin, we want to mimic this type of insulin pattern. So in the last 5 to 7 years, we've had a growth of very different insulins. We have had the rapid acting ones, which are your Humalog, Novolog, and I'm not for sure how to say it, but Apridra. And basically, the Humalog and the Novolog has about a 15-minute onset, 15 to 30-minute onset, and then it's gone in about 3 hours. Now, the last one actually has a quicker onset and actually peaks faster, and it's gone faster. Now, we use these insulins, the rapid-acting ones, because we can almost mimic the pancreas at the time of a meal. So we give a bolus of each one of these insulins with meals. Now, in the past, we've used short-acting. Now, short-acting is our regular insulin, and the onset is usually in 1 to 2 hours. 30 minutes to an hour, and it peaks about 2 hours. And then I look at it as being gone in 4 to 5 hours. The PDF or the physician's desk reference actually says that it can last up to 12 hours. But I think that this is the case in people who have renal insufficiency. It tends to be less rapid than our Humalog and our Novolog, but doesn't work as quickly as, it works more quickly than our intermediate acting. So our intermediate acting insulin is our MPH. Its onset is usually 1.5 to 4 hours, and the peak is 4 to 6 hours, and then I think of its duration as being approximately 12 hours. The long-acting insulin is like Lantus and Levemir. There are minimal peaks associated with these. As you can, if we go back to our original slide, there's always some basal insulin that's being put out, and therefore the Lantus or the Levemir are long-acting insulins that don't have a peak and act like our baseline insulins. Now, who do we need to start insulin on? I'm going to talk primarily about type 2 diabetics and GDMs. If type 2 diabetics come to see you and they're on 2 or more insulin, 2 or more medications, they need to be converted to insulin. If they're on 1 medication and have an abnormal hemoglobin A1C, then they need to be converted to insulin. And almost all type 2s will likely need insulin before the end of pregnancy. The only type 2s that don't need insulin before pregnancy are the ones who starve themselves. They come in with ketosis and they lose weight throughout pregnancy. Now, there's some hints I want to talk with you about. If you have a patient, like a Hispanic patient that has no access to insurance, NPH and regular are very cheap insulins. They can get NPH and regular for less than $100 for a month, whereas one vial of Novolog or Humalog is actually about $120 each. Now, certain insurance companies, they'll either pay for Humalog or Novolog. And for the longest time, I used to always write Humalog and say substitution. And we always got these calls because there's no generic for Humalog. So I just put Humalog or Novolog and then sign it and allow the pharmacist to choose what insulin their insurance pays for. We prefer the rapid-acting insulins, the Humalog and the Novolog, because it improves the hemoglobin A1C by 1% more than regular does. Now, we don't recommend using insulin mixes like your 70-30s, because 70 is the NPH and 30 is your short-acting or intermediate-acting, rapid-acting or short-acting insulin. But there is more hypoglycemia with these mixes than with straight NPH and Humalog or NPH and Novolog. Now, the other thing I will say is with your GDMs, when they come in, I would start insulin on them when they have more than 25% of their values abnormal. Now, if it's only their fasting values, then you don't have to start them on the whole regime. You can use the evening NPH, but if it's increased across the daytime, then I would start them on a traditional dose of insulin. One of the things that we tend to do is we tend to underdose insulin when we start it. Now, if you read a textbook, it says that you use 0.7 units in the second trimester, 0.8 units in the third trimester, and 0.6 units in the first trimester. Basically, I'm getting too old to remember all that, so I just do 0.7 for all the trimesters. So you multiply that by their weight in kilos, and then you divide the insulin dose by 3. And of that, you give 2/3 in the morning and 1/3 at night. And then the morning dose is 2/3 of the intermediate and 1/3 of the rapid acting or short acting. And in the evening, you do a half of the intermediate dose and half of the rapid or short acting insulin, or short acting insulin. If you're using the rapid acting insulin, I add the short acting together and then I divide by 3 and give 1/3 at each meal. But some people say, well, I eat a big dinner, but I don't eat much breakfast except a cup of coffee with cream. I have a small lunch and then a bigger dinner. I might change that just a little bit based on them having a big dinner. So let's do an example of this. If I got a patient who weighs 100 kg and I do 0.7 per kg, that's how much insulin they need, then the total dose of insulin for a day should be 70. So 70 divided by 23 is 46 in the morning, so that's 2/3 in the morning, and 1/3 at night. Okay, so so it's 2/3 in the morning and 1/3 in the evening. Then I go back and I divide my morning insulin into 2/3 intermediate acting and 1/3 short acting. And then at night, it's half and half. Now, if I want to use a rapid acting insulin, I add 15 and 11, and that's 26. I divide it by 3, and that's about 9 units with each meal. But if they say at 9 it's more, I might do 8, 8, and 12 instead of having it equal throughout the day. Now, the most important thing is to educate the patient. If you've got a patient who's got a hemoglobin A1C of 11 or 12, during the first 2 to 3 weeks of bringing her blood sugar down, she literally feels like the air around her is heavy. It's very difficult to move, and it's very difficult to get out of bed. She's tired, she's sleepy, and she thinks that she could be allergic to the insulin. But I tell them every time I start it, you're gonna feel terrible for 2 to 3 weeks, okay? Because your blood sugar has been abnormal for so long, your body's adjusted to that. I'm gonna bring you down, and then you'll feel much better and have much more energy. The other thing I do is I talk with them about hypoglycemia symptoms and signs. You know, the feeling nauseous, being sweaty, feeling shaky. Those are all signs of hypoglycemia. Now, patients think that they should just get a piece of candy and put it in their mouth, and that will decrease or increase their blood sugar and decrease the symptoms. Ideally, we would like to give them some protein and some carbohydrates because it gives a slower rise in the blood sugar and it doesn't cause them to crash on the other side. When you start insulin, I think it's important for the patient to call back in and talk with the nurse in 3 to 4 days. Or if I'm worried about a patient, I might call back and talk with them. And then you see the patient back in your office at 1 to 2 weeks. And the other thing to understand is that clear insulin, because the patients always talk with you about their clear insulin and their cloudy insulin. And their clear insulin is rapid or short acting. Their cloudy insulin is actually the intermediate. Now, I have up there long acting, but Lantus is in a much skinnier bottle than the rapid and short acting. That bottle is more fat and round, and Lantus is actually clear. So the other thing you need to remember is patients can mix insulins. They can mix rapid or short acting with their intermediate or long acting, but they should always draw up their rapid or short acting first and then their intermediate or long acting second. And that's the end of my presentation.
Thank you.